Infertility is classically defined as the inability of a couple to conceive after 12 months of sexual intercourse without using contraception. Sometimes the evaluation for infertility begins at 6 months, depending on female and male factors. Female factors include age over 35, other gynecologic conditions like endometriosis, prior pelvic inflammatory disease, or suspected uterine pathology, like in women who have undergone uterine surgery in the past. Evaluation should also start at 6 months in females with risk factors for premature ovarian failure, like previous ovarian surgery, chemotherapy, or pelvic radiation therapy, autoimmune disease, smoking, or a family history. Male factors include history of testicular surgery or radiation, chemotherapy, adult mumps, impotence, or other sexual dysfunction, or history of fertility issues with a prior partner. The infertility workup is done for both partners at the same time. In males, the semen analysis can identify most causes of infertility. This is when semen is collected in a sterile cup after 2 to 7 days of ejaculatory abstinence, meaning no semen release through sexual intercourse or masturbation, and then analyzed under a microscope. Because sperm concentrations tend to vary a lot between semen samples, at least 2 samples should be collected at least 1 week apart. The standard semen analysis can give information about semen volume, as well as sperm count, motility, and morphology. Semen volume is normally greater than 2 milliliters. Sperm concentration should be above 15 million spermatozoa per milliliter of ejaculate, and total sperm count should be over 40 million spermatozoa per ejaculate. Total sperm motility should be over 40%, meaning over 40% of sperm should be moving, with at least 32% showing forward motility. The last parameter is morphology. At least 4% of sperm should have a head, a neck, and a single tail. That may sound like a low bar, but that's all it takes. Sperm number abnormalities are the most frequent cause of infertility, and they can range from oligospermia, meaning less than 15 million sperm per milliliter of ejaculate, to azoospermia, which is the absence of sperm in the semen. These findings should prompt a morning serum testosterone level and serum FSH and LH levels. High FSH and LH and low testosterone in the presence of oligo or azoospermia suggest a primary deficit in spermatogenesis, also called primary or hypogonadotropic hypogonadism. One genetic cause is Klinefelter syndrome. The karyotype shows at least one extra X chromosome, so either 47XXY or more. Physically, these individuals are typically tall with long legs, a short torso, with broad hips, and gynecomastia, or development of breast tissue. They usually have less muscle mass, less facial and body hair, and a genital examination may reveal small, hard testicles. Another genetic cause is a Y chromosome microdeletion, and it's when one or more genes is missing from the Y chromosome. But there are otherwise no clinical signs. Genetic testing using white blood cells from a blood sample can be done to confirm the diagnosis. Developmental causes of hypergonadotropic hypogonadism include a history of cryptorchidism, or undescended testes. In individuals with just one undescended testicle, sperm count may only be moderately reduced. In individuals with 2 undescended testes, the sperm count may be severely reduced. Finally, acquired causes include viral orchitis, especially mumps, history of radiation in the testicular region, and drugs that impair normal spermatogenesis. Among these drugs, the most important are alkylating drugs, like cyclophosphamide and chlorambucil. Anti-androgen medications like flutamide, cyproterone, and spironolactone, and also other drugs like ketoconazole and cimetidine may inhibit testicular androgen production or action, and also impair spermatogenesis. If the medication is still being taken, then stopping the medication, if possible, can sometimes improve fertility. For individuals with primary hypogonadism, if there's no sperm in the ejaculate or in the testicular biopsy, there currently aren't any treatments available to improve the fertility prognosis. If there is sperm in the ejaculate or the testicular biopsy, some of that sperm may be retrievable and used to conceive with the help of assisted reproduction techniques, like in vitro fertilization, or IVF, in conjunction with intracytoplasmic sperm injection, or ICSI. Basically, with IVF alone, sperm is collected from the male and oocytes are collected from the female, and they're put together in a petri dish to allow for fertilization to occur. With ICSI, a sperm is literally injected into the cytoplasm of the oocyte, which greatly increases the chance of conception. But bear in mind that in individuals with genetic causes, the mutations could be passed down to the offspring, so genetic counseling is required beforehand. Okay, now, if FSH, LH, and also testosterone levels are low, that points towards hypopituitarism, so an issue with the pituitary or the hypothalamus, also called secondary or hypogonadotropic hypogonadism. Most commonly, this is due to a pituitary macroadenoma, which is a benign tumor of the pituitary larger than 1 centimeter. Non-endocrinologic symptoms of a macroadenoma include compression symptoms, like headache and visual impairment. These symptoms typically trigger obtaining a head MRI to identify the tumor. Then, serum ACTH, cortisol, TSH, and T4, insulin-like growth factor 1 should be drawn to check for ACTH, TSH, and growth hormone deficiency, respectively. Serum prolactin should also be determined in this situation, not to assess prolactin deficiency, but rather to screen for prolactin excess. That's because macroadenomas can derive from lactotroph cells and secrete excess prolactin. At the same time, they compress the rest of the pituitary and cause other pituitary hormone deficiencies. Serum prolactin higher than 200 nanograms per milliliter confirms that the adenoma is, in fact, a prolactinoma, which is treated with dopamine agonists like cabergoline. That inhibits prolactin secretion just like dopamine would, and makes the macroadenoma shrink. For all other macroadenomas that are not prolactinomas, treatment is transsphenoidal resection, which is when the tumor is removed through the nose. Hypopituitarism may also be because of congenital GnRH deficiency, which is when the hypothalamus doesn't make GnRH at all. One subtype is Kallmann syndrome, which is when the GnRH secreting neurons fail to form during fetal development. These neurons are closely linked to olfactory neurons, so individuals with Kallmann syndrome may have absent, delayed, or incomplete puberty, as well as anosmia, or absent sense of smell. Other causes of hypopituitarism include head trauma, prior pituitary surgery or radiation, and large tumors of the central nervous system, like a craniopharyngioma, which can also be identified on an MRI. In individuals with secondary hypogonadism, once the underlying condition improves, FSH and LH normalize and spermatogenesis improves after 6 to 12 months. If 6 to 12 months later sperm count abnormalities are still present, exogenous gonadotropin therapy can be initiated. The first step is to initiate treatment with HCG, which has a biological activity of LH and leads to increased testosterone levels. Individuals can self-administer HCG via an intramuscular injection. The initial dose is 2,000 units 3 times a week, always on the same 3 days. For example, Mondays, Wednesdays, and Fridays. Serum testosterone is measured every 1 to 2 months, and the dose can be increased up to 10,000 units 3 times a week, until testosterone levels are between 400 and 800 nanograms per deciliter. At that point, the sperm count is measured every 1 to 3 months, and typically reaches 5 to 10 million sperm per milliliter of ejaculate in about 6 months. If the sperm count hits the target, the HCG dose should be maintained, and a sperm analysis should be checked every 1 to 3 months. If sperm count is still lower than 5 to 10 million sperm per milliliter of ejaculate 6 months later, human menopausal gonadotropin, or HMG, or recombinant human FSH is added, which acts as a surrogate for FSH. HMG is administered as an intramuscular dose of 75 units 3 times a week and can be increased up to 150 units 3 times a week, until sperm count reaches at least 5 to 10 million sperm per milliliter of ejaculate. Recombinant human FSH is administered subcutaneously at a dose of 150 to 300 units every other day for 18 months. If pregnancy does not occur spontaneously within 12 to 24 months of achieving any sperm in the ejaculate during treatment, the next options are assisted reproduction techniques, like intrauterine insemination and IVF with or without ICSI. If serum testosterone, FSH, and LH are normal in the presence of azoospermia and the testicular semen volume is normal, the most likely diagnosis is a sperm transport disorder, which includes obstructive azoospermia as well as retrograde ejaculation. Causes of obstructive azoospermia include the congenital absence of the vas deferens, or obstruction of the epididymis, ejaculatory duct, or vas deferens. Congenital absence of the vas deferens is suspected when the vas deferens can't be felt on palpation, and confirmed by a scrotal or transrectal ultrasound. The most severe form is a bilateral absence of the vas deferens, which can be seen in individuals with mutations in the CFTR gene. These mutations cause cystic fibrosis, but sometimes individuals may have the mutation in a bilaterally absent vas deferens and no other symptoms of cystic fibrosis. Obstructions of the epididymis, ejaculatory duct, or vas deferens can be the result of prior testicular surgery or infections, like viral orchitis in adults who get mumps. They can be diagnosed with a scrotal or transrectal ultrasound. All individuals with obstructive azoospermia should get a testicular biopsy, and if sperm is found, it can be frozen for possible future use in IVF with ICSI. Sometimes, these obstructions can be corrected by microsurgical end-to-end anastomosis to bypass the obstruction. However, for individuals with uncorrectable obstructions, or for those with congenital bilateral absence in the vas deferens, assisted reproduction techniques like IVF with ICSI are the only option. Bear in mind, however, that in those carrying mutations in the CFTR gene, there is a chance they'll pass down the mutation to their offspring, so these individuals should first receive genetic counseling. Retrograde ejaculation, on the other hand, happens when the sperm goes into the bladder instead of out through the urethra during ejaculation. Some risk factors for retrograde ejaculation include prior prostatic surgery, diabetes, spinal cord injury, and taking some psychiatric medications, like thioridazine, chlorpromazine, and amitriptyline, or the antihypertensive drug doxazocin. Retrograde ejaculation can be confirmed by demonstrating sperm presence in the postcoital urine, and treatment options include oral sympathomimetic medications, like ephedrine sulfate or phenylpropanolamine, which have been shown to improve bladder neck closure. If these medications fail, or if retrograde ejaculation is secondary to spinal cord injury, assisted reproduction techniques like IVF with ICSI can be attempted using sperm obtained from the urine sample. If none of these causes are identified for male infertility, then a varicocele may be to blame, especially when it's clinically visible or palpable. In other words, the simple presence of a varicocele doesn't automatically mean that the aforementioned workup is skipped over. Now, if a varicocele is suspected as the cause, then color Doppler examination can be done to confirm the varicocele, and surgical correction of the varicocele may improve sperm count and fertility. If there is no varicocele, then a final diagnosis is idiopathic male infertility, and hormonal treatment with gonadotropins may be tried empirically. Additionally, a diet high in vitamin C and vitamin E is thought to improve the quality of sperm. Now, remember, there's two sides to the infertility coin, so let's switch gears and look at causes of female infertility. In females, the goal is to assess whether ovulation takes place and whether the female reproductive anatomy allows for conception and pregnancy. Ovulation can be presumed based on the regularity and symptoms of each menstrual cycle. Regular menstrual cycles, repeating at a 25 to 35-day interval, along with premenstrual symptoms like breast tenderness, mood changes, bloating, fatigue, and cravings before the onset of each period, suggest that ovulation is happening. Some females also report Mittelschmerz, which is German for mid-cycle pain, that might occur at ovulation. Historically, a way to check if ovulation occurred was to measure the basal body temperature throughout the menstrual cycle. Following ovulation, basal body temperature increases by 0.5 to 1.6 degrees Fahrenheit on account of rising progesterone levels. However, this is not the most reliable method, so nowadays, ovulation is assessed with urine ovulation kits, or by getting serum progesterone levels. Urine ovulation kits have the advantage of being easy to perform at home, and they predict the approximate timing of ovulation based on detecting the LH level in the urine, which normally surges 24 to 48 hours prior to ovulation. Having sex at the time of the surge maximizes the chance of conceiving naturally. However, urinary ovulation tests aren't perfect, so ovulation can be more accurately confirmed with a mid-luteal progesterone level, because after ovulation, the corpus luteum secretes progesterone. This test is usually done on day 21 of an average 28-day cycle, or 1 week before the expected onset of menstruation. If progesterone levels are higher than 3 nanograms per milliliter, then that confirms that ovulation occurred. At that point, the next step is to examine the female reproductive anatomy. To assess tubal and uterine patency, a hysterosalpingogram can be done, which uses fluoroscopy with contrast to see the uterus and fallopian tubes. An alternative is a hysterosalpingo contrast sonography, which is when echogenic contrast is injected through the cervix and a transvaginal ultrasound is done before and after. Both tests can identify fallopian tube obstruction, as well as uterine issues like intrauterine adhesions or septa. Fallopian tube obstruction can occur in females with a history of infections, specifically in pelvic inflammatory disease, infections following childbirth or abortion, sexually transmitted infections like chlamydia trachomatis, or intra-abdominal infections like peritonitis. Obstruction may be proximal, meaning closer to the uterus, or distal, meaning closer to the ovary. On a hysterosalpingogram, contrast spills out into the peritoneal cavity if the tube is open, and doesn't spill if the tube is obstructed. Ultimate confirmation, however, is done through laparoscopic chromotubation, which is when the cervix is occluded and a dye like methylene blue is injected into the uterus. And, just the same, a patent tube will spill dye at its ovarian end, whereas a blocked one won't. Proximal tubal occlusions can be treated with hysteroscopic or fluoroscopic tubal catheterization, or with tubocornual anastomosis, which is most often performed by laparotomy. Distal tubal occlusions can be treated by laparoscopic or laparotomic fimbrioplasty, which is when the fimbrial adhesions are removed or fimbrial structures are dilated to restore patency. Another option is neosalpingostomy, which is the creation of a new tubal opening. In case of irreparable damage, however, IVF is recommended instead, with or without ICSI. Uterine abnormalities include intrauterine septa and adhesions. Intrauterine septa are congenital defects. Intrauterine adhesions, which are bands of fibrous scar tissue inside the uterine cavity, can occur in females who have undergone uterine instrumentation in the past, like dilation and curettage. In both cases, a first line of treatment is hysteroscopic resection of the adhesion or septa. However, for severe, irreparable uterine defects, surrogacy or adoption may be the only options. Cervical factors are a rare cause of infertility, but may be suspected based on a pelvic examination that may show cervical abnormalities and cervical mucus examination, which may show abnormal mucus that might impair fertility. Cervical infertility can be bypassed by using intrauterine insemination, which is when sperm is injected directly into the uterus with the help of a syringe. If that fails, IVF can be used. Okay, now if progesterone levels are lower than 3 nanograms per milliliter, then there's no ovulation. Causes may include either body weight abnormalities, a depleted ovarian reserve, or other endocrine disorders like Turner syndrome. First, weight-wise, both too high, meaning a body mass index greater than 27 kilograms per meter squared, and too low, meaning less than 17 kilograms per meter squared, can interfere with ovulation. So the first step can be to help a person get within the normal weight range, between 18.5 and 24.9 kilograms per meter squared, and that alone can restore ovulation and improve fertility. To assess the ovarian follicular reserve, meaning how many follicles there are left in the ovaries, first-line tests include early follicular phase serum FSH and estradiol levels. So the sample should be obtained on day 3 of the menstrual cycle. An FSH level less than 10 milli-international units per milliliter and an estradiol level less than 80 picograms per milliliter are suggestive of an adequate ovarian reserve. At the other end of the spectrum, a high FSH greater than 20 milli-international units per milliliter and low estradiol levels in a female below age 40 who has additional symptoms like hot flashes and vaginal dryness suggest primary ovarian failure. That's where the ovarian follicles undergo accelerated atresia and get depleted before menopause. Additionally, serum anti-Müllerian hormone, or AMH levels, can be checked. Anti-Müllerian hormone is secreted by primordial ovarian follicles, and it directly correlates with the ovarian reserve, so it gradually declines with age until it becomes very low or undetectable at menopause, or with premature ovarian failure. If everything checks out as normal, then the next step is to rule out other endocrine disorders that may inhibit ovulation. So serum TSH, prolactin, and testosterone should be drawn. Low TSH indicates hyperthyroidism, and treatment depends on the cause. For example, if Graves' disease causes hyperthyroidism, then antithyroid medication, like methimazole and propyltiouracil or PTU, can be used. And if one or more nodules are found on the thyroid gland, radioiodine therapy can be used to nuke them. On the other hand, high TSH indicates hypothyroidism, and in this case, treatment is thyroid hormone replacement therapy with levothyroxine. Correcting the underlying thyroid hormone imbalance can improve fertility. Now, if serum prolactin is elevated, chances are it's because of a prolactinoma, and if one is identified on a head MRI, treatment with cabergoline can be used. Finally, if testosterone levels come back high, meaning more than 60 nanograms per deciliter in a genetically female individual, that could be indicative of hyperandrogenic disorders, the most common of which is polycystic ovarian syndrome, or PCOS. With PCOS, there may also be other signs of excess androgens, like hirsutism, acne, and some individuals may also have obesity and insulin resistance. If individuals are obese and have insulin resistance based on a 2-hour glucose tolerance test, then metformin therapy and weight loss are recommended, and sometimes that's enough to restore ovulation and improve fertility. If weight loss and metformin don't restore normal ovulation in individuals with PCOS, then ovulation induction may be done with medications like clomiphene citrate, aromatase inhibitors like letrozole, or gonadotropins. Clomiphene citrate is given starting on day 5 of the menstrual cycle, an initial dose of 50 milligrams daily for 5 days. Ovulation should occur 5 to 12 days after the last day of treatment, and it should be tracked using urinary ovulation kits. Finally, the couple is advised to have intercourse every other day, starting with the last day of clomiphene, for a week, in order to maximize their chances of conception. If ovulation does not occur in the first cycle of treatment, the dose is increased to 100 milligrams. Once ovulation is achieved, the same dose should be continued for 4 to 6 cycles. If ovulation hasn't occurred under clomiphene induction, aromatase inhibitors like letrozole can be used. Gonadotropins, like recombinant FSH and HCG, are considered when all other options have failed to induce ovulation in PCOS patients. But they may be the first choice in individuals with infertility because of hypopituitarism. Note that gonadotropin therapy used for ovulation induction may cause ovarian hyperstimulation syndrome, especially in individuals with PCOS. The risk is considerably higher when pretreatment levels of serum AMH are higher than 3.5 nanograms per milliliter. With ovarian hyperstimulation syndrome, symptoms range from mild, like abdominal discomfort and distension, enlarged ovaries with multiple cysts, to severe forms with nausea, vomiting, ascites, pleural effusion, hypovolemia, and oliguria or anuria. Sometimes the presentation may be downright critical, with signs of end organ damage, like respiratory distress, acute kidney injury, cardiac arrhythmias, and disseminated intravascular coagulation. Alright, now, a final cause is endometriosis, which is typically considered when other diagnoses have been ruled out. Symptoms of endometriosis include severe dysmenorrhea, abnormal vaginal bleeding, and dyspareunia, meaning pain during intercourse. It's believed that the inflammation that comes with endometriosis can damage or scar the reproductive structures, thus inhibiting the release of the egg, its movement through the fallopian tube, or its implantation in the uterus. The best way to diagnose endometriosis is through biopsy obtained through laparoscopy. Depending on the size and location of ectopic uterine tissue, endometriosis may range from minimal to severe. Individuals with minimal and mild endometriosis may still try to conceive naturally, or they may opt for ovulation induction in conjunction with intrauterine insemination, as well as IVF with or without ICSI. In females with moderate and severe endometriosis, IVF and ICSI are recommended. Finally, in some couples, no male or female factors are identified, in which case it's termed unexplained infertility. In this case, first-line treatment is most often empiric. Particularly, ovulation induction with clomiphene in conjunction with intrauterine insemination may be tried because of the low costs and low risk of side effects. If that doesn't work, IVF with or without ICSI may be tried. Alright, as a quick recap. Infertility is defined as the inability to conceive after 12 months of regular unprotected intercourse. In males, a semen analysis is done, and if there's oligospermia or azoospermia, serum FSH, LH, and testosterone levels are checked. High FSH and LH and low testosterone suggests primary hypogonadism. Genetic causes for primary hypogonadism include Klinefelter syndrome, which is confirmed with a karyotype, and Y chromosome microdeletion, which is confirmed with genetic testing of white blood cells from a blood sample. Other causes include a history of undescended testes, viral orchitis, especially in the context of adult mumps, radiation in the testicular area, or drugs that impair spermatogenesis. Low FSH, LH, and low testosterone suggest secondary hypogonadism, and the most common cause is a pituitary macroadenoma. Finally, if there's azoospermia, but serum testosterone, FSH, and LH are all normal, there may be obstructive azoospermia or retrograde ejaculation. A clinically visible or palpable varicocele may be blamed for infertility if no other cause has been identified. If there's no varicocele either, the diagnosis is idiopathic male infertility. Female infertility may be because of ovulation disorders or anatomical abnormalities. If mid-luteal progesterone levels are lower than 3 nanograms per milliliter, that suggests ovulation isn't happening, which may be because of body weight abnormalities like a BMI lower than 17 kilograms per meter squared or greater than 27 kilograms per meter squared, a depleted ovarian reserve, or an endocrine disorder. Ovarian reserve can be assessed with serum FSH, estradiol, and AMH levels. High FSH and low estradiol and AMH suggest a depleted ovarian reserve, which can be seen with premature ovarian failure and menopause. To rule out an endocrine disorder, serum TSH, prolactin, and testosterone are drawn. Low TSH indicates hyperthyroidism, while high TSH suggests hypothyroidism. High prolactin levels suggest a prolactinoma, which can be confirmed with a head MRI. And finally, high testosterone could be because of hyperandrogenic causes, like PCOS. Going back, if mid-luteal progesterone levels are higher than 3 nanograms per milliliter, ovulation is happening, and the cause is likely because of fallopian tube obstruction or a uterine abnormality, like intrauterine septa and adhesions. Finally, if no cause for male or female infertility is found, the term unexplained infertility is used.